Good afternoon, good evening, and welcome to the 2022 Victor Zhao Distinguished Lecture in Global Health, hosted by the Duke Global Health Institute at Duke University. I am Gavin Yamey. I'm a professor of global health and public policy here at Duke, and I am coming to you live and direct from Durham, North Carolina, USA, and I am very honored to be your moderator for today's conversation. As you can see, I'm sitting in one of Duke's most beautiful and most ancient quads. This is a historic Duke brick behind me. Just kidding, this is vinyl. And I'm in a tiny windowless multimedia room. We have a really outstanding event for you featuring two of the most influential people in global health today. But before we begin, I want to acknowledge a few people without whom this event would not have been possible. First and foremost, we want to thank Victor Zhao and Dr. Ruth Cooper Zhao, whose generous gift to Duke makes this annual event possible. Dr. Victor J. Zhao is the former Chancellor of Health Affairs at Duke and one of the driving forces behind the creation of the Duke Global Health Institute in 2006. He now serves as the President of the National Academy of Medicine, and we are delighted to continue to have the support of Victor and Ruth for these talks. This lecture series is also supported by the Bill and Melinda Gates Foundation, as well as the Duke Global Health Institute team under the leadership of our interim director, Dr. Dennis Clements. And finally, a really huge thank you to our partners at the University of Global Health Equity in Rwanda, where our speakers are joining us from today. You are going to hear a lot more about this very unique university and the great work that it's doing over the next 90 minutes. But I just want to say up front, particularly for the topic of today, is so crucial for this to be a truly global conversation. So, welcome, good evening to all of you in Rwanda. Thank you so much for being part of this event, and we look forward to hearing your thoughts and questions a little later on. So, to today's talk, which is called Restoring Global Solidarity on the Road to Pandemic Recovery. I cannot think of a more urgent or more compelling or more timely topic than this one today. And we have the great fortune to have two of the real trailblazers in global health to help us navigate these issues. First, it is my great pleasure to welcome my friend and colleague, Dr. Agnes Binagwaho. Dr. Binagwaho is the Vice Chancellor and co-founder of the University of Global Health Equity. A pediatrician by training, Dr. Binagwaho served as Rwanda's Minister of Health from 2011 to 2016. She held previous positions with the Rwandan Health Service as Permanent Secretary of the Ministry of Health and Executive Secretary of Rwanda's National AIDS Control Commission. Welcome, Agnes. And our second guest, also a friend, Paul Farmer, the co-founder and chief strategist of Partners in Health, which provides direct healthcare services and leads research on global health issues in many places around the world. Dr. Farmer is chair of the Department of Global Health and Social Medicine at Harvard Medical School, as well as a professor of medicine and chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. Dr. Farmer graduated from Duke in 1982, yay, go Blue Devils, and has served as a Duke University trustee as well as a member of the Board of Advisors for the Duke Global Health Institute. A very warm welcome to you, Paul. So I am going to take the liberty of kicking off very, very informally. Agnes and Paul, can you just tell us how you first met and tell us a little bit about the work that you do together?
And how did we meet?
So we met in New York. I think it was my first travel to New York, by the way. New York was not looking like I knew in the movies. And we were supposed to, I was supposed to join a team of people, high level, reflecting about the MDGs. I have to acknowledge that I didn't really know what it means at that time. And when I entered in that room, there was a lot of people that were good. I didn't know any. And a lot of really stupid, messy people that telling us how to treat HIV, what we should do, etc., etc. However, many of them were very big advisors in entities that decide who live and who die, because they were advisors of the Global Fund. And here we had in Rwanda, at that time, we had 800 people on treatment, and we were really going across the world to find opportunity for treatment. And I was so shocked because, and I told them, if I do what you advise me to do in my country, people will die more. And this guy called Paul Farmer was in the corner of the room, as much as annoyed as I was. And so I sit near him, and when he was opening his mouth, he was saying things that made sense. So that's how we met.
Of course, you know, I could. It's hard to improve on Agnès' storytelling. That's all true, but this was really an attempt to write the MDG. And like her, I was like, what the hell is an MDG, and why should we go to another meeting? Of course, you know, God in her wisdom, you know, that was how we met. And the other thing I learned on that first day was that Agnès was not shy about reminding people why what they were saying was goofy or worse. And she did say, and this went on for days, you know, these meetings. I had actually come from Haiti directly to that meeting. And she said, well, why don't we, as kind of a reality check for all you policymakers and big shots, why don't we have our next meeting in Rwanda? And so, you know, I went, I was on the committee too. And when I got here and we became friends very quickly. And I knew really from setting foot in this country and really working with Agnès that I wanted to work with her, and I wanted to work for her, because, you know, those are the same things. You work with her, you work for her. Did we answer the question, Gavin?
Yes, and tell us what you're doing together these days. Tell us a little bit, both of you, about Rwanda's kind of history of innovation in public health and how the two of you have worked together on some of those innovations.
So we worked together during a couple of years before starting thinking about creating an official institution where we can transfer the knowledge to future leaders, and also the skills that I was never trained to be a global health manager. I was a pediatrician in my unit in neonatology. I was good, I love it, etc. Circumstances make me run the National AIDS Control Commission. So I learned as much as I learned a lot to do my best. And I learned by doing. I just believe that there is a God there, because I could have messed up so much, and I didn't. And we decided to train young people, and less young, how to manage a health sector, because we were lucky through Harvard to write, to study what we were doing, and to put principle behind that in discussion, intensive night discussion. You don't understand how many times we rebuild the world in those hills of Rwanda. And we started by training, short course, 2 weeks, all the leaders of the health sector, all of them, 60 people in the ministry, directors, director of hospital, etc. And the impact was profound. on mission, vision, coordination, decentralization, access to care, focus on the vulnerable, etc. And we realize that here, where it was more easy to give real education to people than in a class in Boston, because we were talking about what is outside the door of the class. We had the discussion with each and every one we were talking about. The mayor come, the minister of state was coming, discussing policies, protocol, practice, all the chain of services. And we decided that now it was time to go to the next step and create a true institution that will give this opportunity globally and continue to be a global platform for discussion, because nothing is written in stone. Everything change and that's why innovation come. Paul, to you.
Well, I'm not going to be so lofty and philosophical. I'm going to go back even further. I would just say, and it's, I was lucky at Harvard to have a boss who said, yeah, you want to go work on health system building in rural Rwanda? Go ahead. And that was Victor Zhao. So it's very convenient to have Victor as a boss, because when I got here, she's talking about policy level decisions, and the health sector cadre, the people who worked with her as minister, before that permanent secretary, before that as National AIDS Program Director. But the task that we were given first by her, there were 30 districts in Rwanda. There are 30 districts in Rwanda, and 4 of them had no district hospital at all. So we were sent to 3 of those 4 districts to either build or rebuild the hospital. And these were all rural areas. And the last one, and so all those years for me were largely clinical service delivery, helping build out the program. But when Agnes says you have no idea how every night, we were building the world again, and we're talking about, we would, spend days and days together talking about these things, working on these things, usually for me out in the rural areas where Agnes was very often. And I just want to say, I hope it comes up because I'm kind of sentimental about it. The last district was the district of Barrera, where we're sitting now. And, I know for a fact that Agnes never saw this place until I did, because we went here together the same day, listening to Nina Simone in a Jeep. And we got to the end of the road, and there's this beautiful mountain, and we looked around, and she said, this is it. You build the hospital here. These are ministry hospitals, of course, and we'll fulfill our shared dream of being able to launch a university focused very specifically on global health equity. So same story, I just reach back a little bit into the kind of work she had me do. As I said, if you work with her, you work for her.
Yeah, but what is important, Gavin, is to understand that we were really complementary.
Yes.
Clinical service delivery,
yes.
Policy making for allowing clinical service delivery, organizing, yes. Because this was 3 sector, but in charge of the 30 sector, we were supposed to provide quality care in an equitable way. So the word equity was a share, and it is in the Rwandan policies. And people like me contribute to the Vision 2020, all those, even revision of the constitution, like many Rwandan, because it was top down on top. But the word equity, health as a human right, in our constitution, it is in, and everything go from there. So that means it was a really a good partnership to do the proof in the pudding, even if pudding is not totally cultural in Rwanda.
That's a very powerful origin story. I'm actually going to go a little bit, I'm going to go slightly left field because what you said, Agnes, really resonated with me. And it reminded me of something that Julio Frenk, former Minister of Health of Mexico, once said, which was about universal health coverage needing to exit the swamp of empty promises. An expression of his that I will never forget, that very often we say, perhaps in our laws, our regulations, our constitution, hey, you have this right. But actually, when you turn up to a clinic, that means that staff have to be there, stuff has to be there. I know, Paul, you've talked about that a lot. So it sounds as if you were trying to, if you like, exit that swamp and provide equitable universal health coverage. I'd love you to say a little bit about that.
What I can say is that if you don't have the legal framework right, you don't protect for long. You'll protect as much as you are there and people like you are there, but a bad guy come behind, destroy everything. At least when you have that in the legal framework, you have the Congress in your country or the parliament in my country to destroy it with the bad guy. So there is a step where the population can have a say. So I'm strongly believing in having the legal framework right. But I also strongly believe that you need to prove that it's right. And it's never right the first time, second, third, 100 times. You have to be flexible enough to change it as you see it. A legal framework is made by women and men for the good of the people, and they have to be changed by women and men for the good of the people tomorrow.
I would just say, Gavin, that the complementarity, we knew that. We felt it ever since, really, I think since the day we met. We felt that, I mean, at least I did, and she says she did, felt that we could be a team. But I had a lot of skepticism about policy work and the swamp of empty promises you mentioned. And, with good reason from previous experience in other places. And Agnes and folks here really made a believer out of me because, 20 years is not a long time. It doesn't seem to me to be working together. It seems like it's, not a short time, but to see all these changes occur with my own eyes and later with hundreds of others and now thousands of others, it was deeply and is deeply humbling to me. And that's something I really learned here in Rwanda. And even the part about, laws and procedures and protocols are made by women and men and they need to be changed. I saw things change again and again with this iterative process. And, a lot of us do credit Agnes with really pushing forward the idea of implementation science or implementation research, because that was part of the iteration to investigate what worked well, what didn't work well, and then change it. And I will say, even though, I had some experience in policy circles before, a lot of it difficult and painful with the other regulatory, with every, the World Health Organization, ministers of health, secretaries of health and human service, and in my country. But this was really the first time where I saw it, push forward to fruition. So it's still a great learning experience for me.
And also, Kevin, for this to work, never take health as a silo. Health is, your friend Julio Frenk used to say, health is too serious to leave it in the hand of doctors. Huh? So that means the laws you need to do that in a multi-sectorial way. Because if you have another law in the local government that doesn't match what you do in the health sector, people are lost. So that means multi-sectorial approach and collaboration. And the solidarity we talk about now have to exist inside the country. And I don't say that Rwanda is the paradise where everything is okay. We still have a way to go. But this solidarity and this collaboration exists. And that's how each sector can fly around the same plan.
I think that's absolutely right.
With one captain called President Kagame.
Your comment about doctors made me think of a paper by Dean Jameson and colleagues. They looked at the fall in child mortality from 1970 to 2000 and what are the factors that explain it. And only 9% of the decline was explained by expanding the number of doctors. I am not anti-doctor, I'm a doctor myself, but I think it was important to remember that there were many other factors, from educating girls to clean water to vaccination, truly multi-sectoral, as you said. I wanted to
Gavin,
pivot.
if I could interrupt and just to brag one more second about Agnes, and what I saw here in the early 2000s, the National AIDS Plan, which, again, I'm not real keen on reading those kind of things any more than I am in going to meetings in New York, or Geneva, or, et cetera. But when, it would be, I would be remiss not to point out that this approach was already written into the National AIDS Plan 20 years ago. And when I say this approach, I don't just mean the, multi-sectorial or any, whatever the term of the day may be. Social solidarity, food security, gender equity, again, the social and economic rights that we know allow people to flourish. So this is, it was more a flash of recognition. Aha, that's what we want to see elsewhere. And so that was also a very uplifting thing to learn from the way the National AIDS Program was being implemented.
Thank you, Paul. So I want to pivot now to pandemic, to global solidarity, to issues of nationalism, very light issues for us to touch on. Can you just quickly give us a status of the current pandemic in Rwanda and what some of the remaining issues are there?
Oh, I had promised myself to look at the data of yesterday, but in Rwanda, it's okay. It's well controlled. And you know why?
Good.
It's because the population, the vast majority of the population trust the health sector. Remember the study done by Wellcome Trust 2019 published that the rate of vaccination of kids in this country is the highest on earth. And this because the population trusts. You need to trust the authorities that execute, that do the law, and also that can protect you if you are mistreated. So, and also the government never lied for COVID. When they didn't know, they didn't know. When the world say no mask, they say no mask. When the world say mask, they say apologies, everybody put a mask, and don't try not to put it. We just learned that we should put it. You understand? So telling the truth and move with the science as the science go. So with that, even without having vaccine in the beginning, the pandemic was well controlled during the lockdown.
Don't stop first, but let me just say, being a native of Florida, let me just tell you,
nobody's perfect.
Nobody's perfect. Florida has its charms if you didn't have to live in Florida. But, to go from, Florida, Miami at the height of surge, whatever, to here, and especially out in the rural areas, I mean, it was just stunning. We have all these political battles going on in the United States, mask, no mask, conspiracy theories galore, which are still rampant. To come here and travel for the 3 hours between the capital city, where everyone was masked, and where by the way, that's probably where I got my first COVID test too, because it was easy to get a COVID test. And it was easy to quarantine until the results were out. But coming up here into this rural area and seeing people who are largely peasant farmers, whatever the term may be, that's what we say in anthropology, to see everybody masked was stunning. And, I'm on service at the hospital right now, Gavin, and seeing mostly very sick ID patients.
Yeah.
And I have not yet seen a patient here at this hospital that hasn't been vaccinated. And
it's remarkable.
It's just worth saying.
Absolutely. Yeah. So the authorities in Rwanda run after the world to get vaccine, and we have 70% of our people above 18 vaccinated, even more. Now we go to 12 for kids that are at school and
Yeah.
crowded school. What is beautiful, Gavin, is that when the list of people who have to be vaccinated, health workers, community health workers, people with underlying condition, was done before any vaccine was at the horizon, managed by the Prime Minister. And when the vaccine arrived in the country, in less than 24 hours, they were in 500 places equitably distributed in Rwanda, in all health centers, all sectors have a health center. And they start to vaccinate the people at risk, were done in a decentralized way by the doctors and nurses, etc. But also priority list, prisons, because crowded, refugee camp, because on the soil and crowded. So this approach with a focus on the vulnerable has also made this country what it is. And I'll say again, the country, we are not in paradise, but it works. And when people want to be vaccinated, remember, it's the same thing that I was HIV positive. We have only 3,000 regimen per day. Who are we going to serve? You put the civil society in the selection committee. People who are not served are sad, but not frustrated, because there is a list that is clear and transparent without nepotism or something like that.
And this is what
is the same.
This is what we should have done worldwide. I was very early on involved in advising on the setup of COVAX, a global vaccine sharing mechanism. It has had many challenges, as everyone knows, but that was the vision, that 20% of the world everywhere should be vaccinated first. High risk, elderly, health workers.
You know that the vision of people in high-income countries are very short-minded. So
Indeed.
They had the vision, but not behind the door. So,
indeed, and that's actually my next question. There's a question actually that's already popped up from someone listening, which is very related, from Adis Kasahun in Ethiopia, who actually was a policy fellow with us here at Duke some years ago. And he would love your reflections, both of you, on the sort of the nationalism we've seen in rich countries, turning inwards, vaccine nationalism, hoarding of doses, refusal to share the patent. What are your reflections on this kind of nationalistic response in this current era?
She just gave me the Rwandan signal for you first. Well, and you know this as well as anybody, Gavin, it felt like a slow motion disaster, right? I mean, the predictions that this would happen, vaccine nationalism and even vaccine apartheid. How many times did we hear that even before the vaccines were available to anyone? And so, that was and is very painful. But I mean, it's hard. My research or my other work is also on epidemics. How they move through populations, etc. So this is very familiar to those who do that kind of work. But it's just important to say that the worst possible time to have nationalism or any kind of sectarian thinking is during a pandemic, which by definition is across national borders. So I in addition to being painful, I came back here and said, well, if 99% of all the vaccines that are used on this continent are manufactured elsewhere, of course Rwanda is going to try to move forward local production on the continent. There have been other countries, Senegal, Morocco, South Africa, even Egypt, that have pushed this, but I can't help but betting that it's going to be likely to come to fruition here. And also finally, I'll stop. But another thing that really disturbed me, working between Haiti, the United States, and Rwanda, was during the recent Haitian crises, there were a lot of people, meaning presidential assassination, an earthquake, gang violence. I mean, it's hard to get more apocalyptic than that. And I couldn't believe it when I heard people in the global north saying, you see, you can't give them vaccines, they'll just waste them. And then you think back to smallpox, which is every public health person, even the public health Luddites, like to talk about. In states in India, sometimes there were, 20 vaccines per child that were, logged in before victory was declared. And here we are disparaging people in the global south or programs in the global south as being somehow uniquely incompetent and unable to roll out vaccines. Now, of course, I knew Rwanda would do a great job, and I'm really hoping that vaccine manufacturing does move forward here as they plan.
Absolutely. And also, nationalism was there before COVID, Gavin. Remember your previous election, okay?
Well, whether you think of him as British or American.
No, I didn't finish there.
Either way.
Continue to UK, continue to Netherlands. Netherlands, thanks God, listen to your former president before voting and decide, no, it's not a good choice to go for nationalism. They chose the other one. But that means it was there. History, situation, context make health. So the health depends so much of that it's for many a reason to die. And I don't believe it's the vaccine who have created. It's just a symptom of what was there before. Remember, first instruction, bound Muslim, not people from a country, people from a religion. So that's COVID came over that. And that's what we have to say.
I totally agree. Even before the vaccine, and actually very early on in the pandemic, we're going to be doing political economy studies for decades, but some of the countries that, clearly, I think early on did very poorly had populist male nationalist leaders who turned inwards and rejected science, from Brazil to the US to the UK to Russia and elsewhere. So I'm sure there's something in that. When this lecture was being organized, I was kindly asked to moderate. I went on Twitter and asked the world, what would your questions be to Drs. Binagwaho and Farmer? And one of the most common was, and you touched on this earlier, that are you seeing parallels? You are veterans of the struggle for HIV justice. Are you seeing parallels with COVID-19 and the response to HIV/AIDS?
150%, just to not be scientific. Absolutely, Kevin. Science was out when it's a matter to not share. There was something that we not so much talk about. Many people in the rich country were afraid to give drugs to the poor country, say, they will create resistance because they don't know how to take it. So it was self-protection. Die, my brother.
Yes.
I don't care. I want to remain alive. So yes, it was the same. Deny the IVs. Yes, it was the same. Conspiracy theory, of course, it was the same. How many things we saw that we got AIDS in Africa because there was sex with monkeys and things like that. So and also with the sexual orientation, etc. So yes, lie, trust, nationalism, lack of sharing, patent, fight for keeping the recipe of a life-saving tool, and if you die, it's not my problem. Yes.
And on a brighter note, on a happier note, just another thing worth mentioning, and this was true with Agnes and the team in Rwanda, but also the need to work with activists. I mean, we're working with AIDS activists, including Prep for All, on these issues of vaccine nationalism and how that might be countered, and in the short term as well to save lives. And so, although that long litany of very, troubling resonances is anybody would see it. And also the one that you made, Gavin, about leadership and failure of trust. We've seen all of that in the global pandemic, but are reminded that, you know, AIDS activism and, you know, attention to the rollout with staff-based systems in sport, you know, this will keeps fueling us. We know we can do better. I mean, we know they've done well here, but we know we can do better in the United States. We know we can do better everywhere.
But the activists did well in the United States. They did well. I have to say that if things change, it's not because of political will of rich countries, it's because of the tenacity of the activists from New York to Europe to South Africa. So this is a lesson that we don't yet see with COVID. Yes, there is a lot of movements, but the other movement and the vaccine negationists are as much powerful. So we need to rethink what has worked well and why, and try to adapt that, because we could do far better. We know more, we have experienced more. For the world, we have to do better.
I mean, we are seeing activism around vaccines. Hashtag people's vaccine. We certainly need a people's vaccine, I would argue, where the patent is shared, the technology is transferred, and vaccines are manufactured worldwide. So I think there's been some inspirational activism there. I wanted to ask you a very specific question, Paul, from Twitter, from a Dr. Eric Reinhardt, very interesting physician, psychoanalyst, and anthropologist of public health, who said, Partners in Health has defined itself against both crisis models and top-down single disease interventions, you know, that have characterized many global health initiatives. What do you think are the risks and benefits of those paradigms, using a crisis model and using a top-down vertical model? What do you think are the risks and benefits both now and sort of as we plot the era beyond this pandemic?
Well, first of all, thank you, Eric. If you're listening, I would just add, know him well because he trained at Harvard. But let me just start with crisis mode. You know, first of all, you can imagine, and we did, and you know, I'm just thinking about George Floyd as well. I can't help it. If you take a crisis and make it mean something better than that kind of crisis mode is okay. For example, after the big earthquake in Haiti in 2010, you know, we tried to seize that moment to put in place a la Rwanda, a public hospital that is a tertiary hospital that could manage trauma care. This was utterly dismissed by the public health Luddites I'm deploring. And you know, once very publicly in Port-au-Prince at some meeting about this, someone said, well, this is hardly the time. This was not a Haitian, of course. I won't mention her nationality, but let's say it has a long entanglement with Haiti, slavery. You know, said this is hardly the time to be thinking about building a tertiary hospital in Haiti. I'm like, well, if it's not, you know, Eric, I had the guts to respond publicly, even though I don't love conflict. I said, well, now, if now is not the time, after the complete destruction of all of Haiti's teaching hospitals, to build another one outside of an earthquake zone, then when would it ever be the time for you people? I didn't say you people, but I thought it. So, you know, the reason we're frustrated about
I think we may have lost our connection with Rwanda.
Hello?
You hear me?
Yeah.
Oh, hello? We missed you.
Hello. You know, I would like to know that whenever I start complaining about the French, they launch some cyber attack on me. But this thing, before so sauvagement interrompu, before so rudely interrupted, you know, that was, you know, this taking a crisis and making it into, giving it meaning and recovering can happen, right? I mean, look what happened here after the genocide and war. So I would say it's not that, crisis thinking isn't bad. It's not that George Floyd's murder couldn't lead to something better. It's just there are specific problems, and they are, Ebola, for example, in West Africa. You hear that there are billions of dollars in pledge. You can bet that it's not pledged to rebuild a health system that shattered after war. So I just want to say it's what we make of crises and how we fail to do something that's bad. As for vertical programs, Eric, you can think of good vertical programs too, like some family plannings and women's health programs are quite good. When I was training at the Brigham, in infectious disease, the best people, clinically were the HIV nurses, right? But there are far more risks and downsides to either short-term emergency assistentialism and vertical programs than there are strengths. So, I think if we could just remember that our efforts, whether in the midst of a crisis or in delivering highly specific services for a particular problem, have to be embedded into health systems that provide a safety net for everyone. And as Agnes said, particularly the vulnerable.
Absolutely. Yeah. And also short time emergency action integrated in the health system.
Yeah.
Everybody is complaining about HIV money. I never. As the first day I receive it, before not having it, because we build the health sector with it. You create lab for people with HIV, it serves everybody. Antenatal clinic, it serves all the women. Delivery room, it serves all the delivery. And after that, internal medicine, because they're all, it's infection. So you need, you treat all so that means if you know how to manage a health sector, embedding everything you do in primary care, universal health coverage, geographic equity, gender equity, age equity, etc., give me the catastrophe and the money that goes with it.
In fact, in class just a couple of days ago, we were talking about vertical versus horizontal program, and I talked about both you, Agnes, and you, Paul, as examples of where you've used what was, in theory, vertical funding, also in Ethiopia, to build out a system, sort of a diagonal approach. So I think that's quite a powerful point. I want to turn to
and I'm a neonatologist. If you give me money for neonatology, I will save all the grandma.
Yeah.
I'm going to, in a couple of minutes, I'm going
How
to turn.
How can you beat that? I want to get my first tattoo with, give me NICU money, I'll save grandma. Okay?
I'm going to ask just one last question, and then I'm going to turn to our students. And that is a very simple question, which is just, the future of global health in a nutshell. Perhaps you could answer very briefly, maybe as a haiku, the future of global health. No, seriously, has COVID-19 shown us that transnational collaboration is a mirage? Or do you think there is a future for global health cooperation, and what might that look like? What have we learned on how global health needs to evolve?
We talked about vaccine apartheid. We talked about vaccine nationalism. I have, and Agnes does too, but I'm just giving a personal answer to that. When we talk about decolonizing global health, it's a good idea to look back at, well, what were colonial health systems like? And in the experiences I've had, having, whenever you can make the time to look at that, or one of my students, Luke Messick, just wrote a great book about colonial medicine in Malawi. But, in going to West Africa, from Rwanda, by the way, to respond to Ebola, we knew that we'd be there for decades, and so we are, right? But even though Agnes never gave me like 5 minutes off to read about Rwandan history and culture, all the things I would have dreamed of doing as a anthropology graduate student, I did say in West Africa that I was going to insist on learning more about Sierra Leone particularly. And just like in Malawi, just like elsewhere on this continent particularly, there really wasn't such a thing as colonial medicine. There was colonial disease control, and that's where some of my rancor against public health Luddites comes from. And just as one example, in Sierra Leone, which was under, no offense to you, Gavin, under British rule for not 100 years like most of the rest of British West Africa, but 200 years. In those 200 years, they saw fit to found all of 0 medical schools and 0 nursing schools. They also saw fit to ban Black doctors from the colonial medical service in the 20th century. So, what kind of commitment could colonial medicine ever have to actually providing care? So I would like to see global health move forward only with the E on the end, global health equity, to be committed to caregiving, to providing services, the kind of services that people ask for in the public sector when possible, and without some burdensome user fee and neoliberal strategy, and with a decent health insurance system. I think that we in global health should not forget that caregiving and higher education were what was left out of colonial medicine. And that's why we're sitting here providing tertiary services when they're needed right here in this village and town, and used to be a village, and sitting in a beautiful university so that people who've been, people who did not benefit from centuries of investment in universities can nonetheless make their way forward.
No, I just want to say that during the colonial time here, even if we are not a colony, we was a tutorate, but Belgium doesn't know how to read the difference, So we were not allowed to study medicine and geology, not know what you have in case you have riches in your soul, and how to keep your people healthy. However, even here, if the colonization of global health has been really evidenced by COVID, we have also this new movement that it's out there to decolonize. I have a lot of hope, even though too much bias in the geographic area where the white people are the majority and where the Black people are the majority. COVID has shown Africa that we can manage when we don't have white savior on your back. When we have, and that the first time African president decide to manufacture what we need. So it brings good things. And also, Rwanda produce no vaccine for the moment, but we have 70% of our people above 18 vaccinated. So there is a certain form of solidarity we need to acknowledge. And also make the difference between the big pharma, the big politician, without courage to talk about science when they know they prefer to keep their seat, and the people. Unfortunately, today the people are so misled. There are so many lies that they don't know how to find their way. So it's our job, global health fighters, to put order.
Let's turn next to the next generation of global health leaders, our students. We have asked some students to send questions in advance. We've asked a few of them to ask their questions on camera. First, I'm going to invite Laurie Babb. I see you there, Laurie, a second-year student in our Master of Science in Global Health program at Duke, to ask the question. Over to you, Laurie.
Yeah, hello, everyone. So I want to thank Dr. Farmer and Professor Adnes as well for just taking the time to speak with us today. I was honored to hear from you last year in the program as well, and I'm honored to be able to ask a question today. So the question that I would like to ask is, in this current age of intense divisiveness within the United States of America, what actual steps can we as global citizens take today within our local communities that will help foster and move all people towards global solidarity? So it's for both of you.
You start.
Okay, so I think what you have to do is to care. Just care, compassion, go, explain, take time, knowing that sometimes it's boring. Sometimes it's you are a little bit fed up to talk to a wall, and you have to convince yourself. My assistant will tell them will tell you how many times I say, last time I do that. And I come back because it's our duty, you know? Bad guys doesn't have more persistency that we have. We need to be persistent and also show people that they matter. Show people that they are biased about their non-value or about their hyper-value. So prove, act, and love.
Amen. You know, I'm glad I asked you to go first, but you know, you can't do better than that. You know, people all over the world have crazy ideas. Any anthropologist studies that, you know, and I'm thinking more of like California than I am of Haiti. Anyway, but you know, to launch into, let's just stick with vaccine hesitancy or conspiracy theories. You know, I wouldn't dream of attacking those in Haiti. You know, people are allowed to have the ideas they want. And if we can't respond with love, with compassion, with patience, you know, then I think we're going to remain stuck. I do think that it's a shame, but you already said that you know, we're facing these problems so much in the United States now. But you know, I can't think of any other way than to be open-minded, humble, gentle when you can, you know, in the course of this work. People have different reasons for distrust, for division. It's very, it's scary to me, you know, when someone like Tony Fauci can be demonized, one of my closest friends, and, you know, one of our friends, you know. And at the same time, you know, I know that, you know, coming out swinging on things like vaccine hesitancy or conspiracy theories, I've never really seen it work. You know, it's really solidarity, compassion, patience. Those are real virtues.
And take time. I have close friends who are vaccine hesitancy. My sister will tell you. Every day we exchange. And I say, if you love me, go and vaccinate. We continue the exchange. Save their life, you know. And you have nothing else to do. It's our job.
The Pope says vaccination is an act of love. Thank you, Laurie. Next, we have a question from Lisa Gashara, one of our global health students here at Duke. She is also host of the Global Volumes podcast. Lisa, take it away and feel free to tell us about your podcast.
Thank you, Professor Amy, for that lovely introduction. Yes, like he said, I'm Lisa Gashara. I host Global Volumes, where I like interviewing people on their journey in global health and how they got to that path. I wanted to ask both of you a question. As we are preparing to work in this field, and as we've seen some changes from COVID-19, from what we've observed and the changes that will happen in the field because of the pandemic, both direct implications and underlying injustices that were highlighted in today's discussion, how can we as students begin preparing for this to work in the field?
Yeah, see what I said? I take direction from her. She goes, little hand gesture, you first. You know, it's a great follow-up to the previous question, right? I'm just going to say something as a little advertisement for Duke. I got involved in global health equity at Duke. I took a class called medical anthropology. I only took the class because it had the M word in it. You know, I was a biochem pre-med major, and you know, we were supposed to do a research paper, and I did. I was very excited to do it. And I was actually allowed into the Duke University emergency room, you know, and I was looking at race, class, and gender in emergency room utilization, you know, and I hadn't learned terms like structural violence. I was just learning about this. But in other words, what I'm saying, which is kind of old fuddy-duddy professor way of saying it, is what we can do now to prepare for responding to these emerging problems or these ongoing problems is really to learn about them too. Adding that to the prescription, talk to other people, listen to other people, learn to have not cultural competence, but cultural humility, you know, and that requires, I mean, that fosters the kind of understanding, I think, that would help us move forward in attacking these very big problems that you bring up. And again, I'm sorry if that sounds, very predictable from a medical professor, but, a lot of times we know from our own experience that we see some devastatingly complex problem and we can't possibly know enough about it, but we can learn more about it.
Yeah.
So I wouldn't forget that part of it.
So be the best in what you do. That's first. Second, and something that will make always you succeed in what you do, focus on the most vulnerable. And never try to save the people without them participating. Talk to the people, and ask them how you can help, how you can be at service. So this, if you know those 3 recipes, you are very good to go. Can never
Lisa,
be wrong.
there's lots of comments praising your podcast, so you're already a big hit, apparently. Oh yes, go ahead, Paul.
No, that was a thumbs up for the
Thumbs
podcast.
up, sorry. Thumbs up. You got a thumbs up from Paul Farmer. So a few weeks ago, Matthew Cohn, who is a friend who teaches at a local high school here, Carrboro High, reached out and asked if some of his students could post some questions or propose questions. So hello, Mr. Cohn. And the students' questions were just fantastic. So we've invited 2 Carrboro High School students to ask their questions. First up, Claire Gitterman, who's a junior. Claire, over to you this moment.
Hi there. Thank you so much for speaking with us. So you touched on this some earlier, but I've been looking into willingness to take the vaccine in different lower income African countries, including Rwanda. And the studies I looked at showed high willingness to take the vaccine in Rwanda, but reluctancy in other African countries. So for you both, what has vaccine rollout been like in Rwanda? What strategies have been employed to achieve this general willingness to take the vaccine, or has it just been the strength of the health system itself that has created this openness towards the vaccine?
So in Rwanda, the people knows that the government will never go against them and will never allow expired vaccine to enter, wrong medicine to be given them on their behalf. They know that. That's enough. If the Ministry of Health said that the vaccine are good for you because A, B, C, D, people will trust. And recently, when WHO tell that a booster is not good, it was cut, but it was in the press here all over. The Minister of Health went and took time there to go and explain. They explained to parliamentarians, they explained to mayors. So mayors talk to their people, parliamentarians go back to the district and talk to the people. Multi-sectorial approach for the good of the people. You got it? So trust, that's it. Elsewhere, even in many countries in Africa, they said, if they send us vaccine, they will be probably out of date or not good enough or not well kept. So I don't want vaccine coming from the white people, except if the leader I trust tell me it's good. What happened with those vaccines sent with only 3 weeks of before expiration? So people say, no, it comes from I don't want them. There are 10 African countries who have refused because their people will not take it anyway. So trust is multidimensional, but you never create the trust in the middle of the crisis. Trust is a long day after day after day after years journey. Don't try to lie in the middle and believe that the people you lie to will trust you.
Just to add one, first of all, I'd like to say hi to my friends at Carrboro High, and to your teacher, my pal. But let me just add to that. I could pretend thinking as an anthropologist. I'm not going to do that, but we're sitting on way up on a mountaintop, just not more than a few miles from the Congo, the DRC, right? And if you go over that border, what you don't see is a difference in language, culture, the way people look and dress. It's really not different, right? Why would it be? These are colonial constructs, these boundaries. But what you do see is a huge difference in trust, right? So let me give an example rather than being way up in the air, but I think it's applicable to vaccines and therapeutics and diagnostics for COVID. So a colleague of mine who has been a guest at Duke a number of times, Gene Richardson, we met actually, and he's also a physician anthropologist and now works at Harvard. He's a professor at Harvard. I recruited him, during the Ebola epidemic because I was very impressed by him. And when another Ebola epidemic happened in DRC, not that far from here, I said, you know what? I'm too old for this one. You go. And off he went. But there was one big difference from 2014 and 2019, I think it was. And that was we had a good vaccine, right? And on this border, and I met him here on the safe side of the border, actually, went and picked him up and said, what was it like? And he was describing how little success they had doing ring vaccination with the new Ebola vaccine or newish Ebola vaccine there. Meanwhile, just a few kilometers away on the Rwandan border, everybody was vaccinated who was involved in the response with no trouble, right? So, what is that? It's not a cultural difference. It's not a cosmological difference. It's not even a political economic difference. It is a difference in what you would expect from responders. And, that's just an illustration, I think, of what Agnès describes. And if you think about what happens over there on the Congolese side of the border, and this is what Gene Richardson described it in his new book, he called it, it's not mistrust, it's eluding predation. It's running away from people you're scared of, right? And on the other side of the border, we just don't see that kind of fear. I mean, we're right there, literally, look outside and that's where we are. So I think that is in a way a very optimistic thing to say, right? Because you don't have to change everybody's culture. You don't have to change everybody's everyday, love for their family or the way they interact or the way that they talk and think and believe in causation. What you really need to do is put in place trustworthy systems that are there to protect the most vulnerable and to protect the people. And I think that's something we've seen done here really in the last 20 years.
And this reflection is really full of hope, because in Rwanda, we managed to do that in 10 years. After a country where trusts were less than totally disappear. I remember entering in this country, I will not let my cup without surveillance because I was afraid. Trust has been created in less than 10 years across the country. Yeah. So that means everybody can do that across the world.
And
let me add just, go ahead, Paul.
No, I was just going to say, and as an American, a Florida man, that gives me hope for my country, my other country. I feel very grateful to have been born there. I've been certainly extremely fortunate, and I'd like to see that kind of trust emerge. I won't say reemerge because I don't believe it. You can't have Jim Crow. I mean, the university like Harvard, how can you have a great university when it's only for men or when it's largely for white people, And it's the same, at Duke and across the world. Our institutions have to be reconfigured, rethought. We have to work to build trust. We have to address, historical grievances to rebuild trust. And to see that happen so quickly here, it's been a gift of a lifetime. Sorry, Gavin, I interrupted.
So trust is one of the biggest social determinants of health.
I think that's right. And Claire, just to reflect on something local, we have a colleague here, Lavanya Vasudevan, who works on vaccine hesitancy locally in Durham and North Carolina. And she has found that the best predictor of whether someone gets vaccinated is whether their trusted health provider is vaccinated and explains why they vaccinated themselves and why they vaccinated their families and kids and so on. So I think trust is really central. Final question from Cabra High School. Please welcome Eikther Kalipali, also a junior. Aether, over to you.
Hey y'all. This question is posed to the both of you. I plan on working in the medical field, but I also do have a really strong interest in combating social inequities and like other such like social justice topics. And it's been kind of hard to like rectify the two when I'm really interested in practicing medicine, but I also do want to try to impart like pretty large scale change. And my question is, how can, in regular practice, can healthcare be used to forward health equity? Or in other words, how can medicine be used as a tool for social justice?
Medicine as a tool for social justice. Wow.
Absolutely. Great question. Go ahead.
You know, thank you. And yes, no, I mean it. I think I know why you pointed to me. Well, you know, I'm as I mentioned already, you know, I'm on service at the hospital. And I also made the claim that, you know, one of the best ways we could decolonize global health is to actually provide services, caregiving, right? And you look at the wounds in, just take North Carolina, for example, and probe deeply there, right? So there are a lot of people in the United States who are poorly served, underserved, and really not served at all. And so I just want to say, although we've heard a lot today about the importance of legal frameworks, you know, policies, and very ambitious population-based interventions, we've heard a lot about that, and we should, but don't forget that, you know, if you're working as a clinician, a nurse, a doctor, a social worker, a community psychologist, a clinical psychologist, if you're doing any of those things, you can bet that you can choose to focus on the vulnerable, as Agnes said, or you can go along more well-worn paths that really probably don't directly serve a social justice goal. So I believe that clinical services, particularly for the underserved, need to be an important discussion always in any discussion of social justice and health. And the reason I keep insisting is because I've never not heard people say that in the places I've been, where they're underserved areas of the United States, on a Navajo reservation, in a poor community in a big city, or, you know, in rural Haiti, rural Rwanda, Malawi, Lesotho, et cetera. I've never heard people not say, hey, we actually need medical care and higher education. I hear it again and again and again. Now, I worry when I don't hear that said in university-based discussions of decolonizing global health. If we skip over that, that means we're not doing our job of actually listening to what people who were not beneficiaries of colonial medicine, which I've already said is the great majority, we're not listening closely enough to them. And apply that same kind of logic to the United States, east to west, north to south, and you'll find very applicable, a lot of these lessons are applicable there as well.
And you can apply those principles in your day-to-day work, even if you are in the same community. Power dynamic. You are already in power position when you provide care to somebody who needs you. So the way you behave, the way you adjust to show that you are at service will be a snowball for that person to act like that, etc., for your colleague to imitate you. So yes, global health starts where you have your 2 feet, whatever feet you have, whatever place you are. And you are the center of the change, whatever you do.
Thank you, those were great. We seem to have also now lost Gavin, so I guess technology is just working against us today, but I will continue from here until we get him back up. So at this point, I want to thank the students for their wonderful questions, and I would like to move on to a question from Dr. Zhao. Dr. Zhao, if you would be able to unmute and ask your question.
All right, technology works. Well, you know, Agnes and Paul are my 2 heroes. And just listening to them really inspires me so much. And Paul talked about learning from me. I say that I've learned so much more from you and from Agnes. And, you know, if you look at the lessons in COVID, You've talked about nationalism, trust, solidarity, and upon the issue of equity. I think that because all this lessons learned, we are redefining what global health should be. It's not just the global North point of view, it's everybody's point of view, particularly in global South, as Agnes pointed out. But I want to talk about education. I do think, and I agree totally with them, that the starting point is that we need to train, educate people about these issues. Now, your University of Global Health Equity is an exemplar of really teaching people the fundamental values. And when I look at the Carver student, Etka Kalipadi's question about social justice, I think she's spot on. I'm not sure how many of you saw my article in Lancet in November, in which we talk about redefining academic medicine. Paul, you like this, and Agnes. You know, when we were trained, we think about bench to bedside. And then, of course, over the years, we think about bench to bedside to population. In this article, I talk about bench to bedside to population to society, the issue of social justice. At the end of the day, as Agnes said, we need to take this on and we need to teach our students how important this issue is. And it's not just the issue of social determinants, it's about equity. It's about understanding that social constructs and racism and biases really are the many issues that affect all us, one of which is health equity. So to address this issue, I have said the medical school and health professional schools should start with students in the preclinical years, working in the community, understanding the issue of social equity before they start doing clinical work or before they even understand physiology or anatomy or whatever. I'd love to hear where you are in your issue of your university, and I'd love to see what we can learn from it, from you, and I would love to hear your response, your point of view about the article I wrote and my point I just made. Thank you.
So I think you have get it all, Victor. I think before putting physiology and biochemistry in the head of our student, we need to put global health principle in the heart. Then, if the seed take, there will be great clinicians with all the good practice needed to really to focus on the vulnerable. And also it's more than global health because it has an economic impact. One study of UNICEF has shown that when you invest in the most vulnerable children, you have 4 times more outcome. It's certainly the same everywhere. And if Rwanda is here today, we are still at the number 167 countries for poverty, $800 per capita. Come and see, you cannot feel it. Just because there is an inclusive governance and development. And again, it's not perfect. So we need to train students as you have described. Here also, they have to go to the community and provide service where the people live, because medicine has something that is a little bit distorted. We institutionalize too much care. So much can be given at home where the people live, where you, without disturbing them, make them less stressed. It's so criminal. I tell to the world, make me die at home. Don't let me die in white shit with people I don't know, except if you hate me. So what you do by bringing global health in the heart of the student first, and after that, bring clinical knowledge, they will adapt to that. So it's what we do here. And also by teaching our students in rural area, we make them appreciate to live in rural area where there is too few doctors and nurses, etc. And normally, young students and less young are educated in cities after they don't know how to come back in rural area. So this is also something we have done.
And Victor, you know, first of all, thank you for writing that piece. and let me just say that this was built in, and you know this already, but it's worth sharing with everybody. This was built into the curriculum here, even in the planning stages, you know, the idea of service to communities. And again, the idea of service to vulnerable communities. The rural argument was made by Agnes, but I would just say right now, the first class to start is in their 3rd year. So I'm working with them in the hospital, particularly with those in internal medicine and infectious disease. And they've all gone through this now. And they have a literacy about and you know, a lot of these kids are not from, they're from, you know, rural areas themselves, but as time goes by, as across Asia, South America, North America, as time goes by, there'll be more and more from cities, right? And these young people, I'm not going to call them kids because they're so impressive. Not that kids aren't impressive. These young people are fluent in these concepts. They are accustomed to visiting people in their homes. They're accustomed to worrying about things like, does everybody in this family have shoes? So whether they want to be, you know, a cardiothoracic surgeon or a primary care doctor or a community-based psychiatrist, regardless, I mean, in my 3rd year at Harvard Medical School, when I was doing rotations, I can promise you that all of us, were nowhere near as fluent. So this, again, you've always said this, you know, by focusing on education, that's where we're going to get the real purchase on social change going forward. But I'm really happy to tell you, and you already know this, that it's readily evident here. And another thing I said to a friend of mine who's here tonight, who's a director of the hospital, a clinician, you know, is that these students also have a lot of confidence. They're not brash. They have cultural humility, but they know what they know, and they're not afraid to say what they don't know. And even in the hospital today, you know, I've heard a number of the students talking about the home visits they're going to do on the weekend. It's like this every day here. And I think we should do a lot more, as you said in your piece, to make sure this is front and center in academic medicine. And at least let's make sure it's not devalued as some kind of hobby or obsession, or isn't that cute, you know, let's indulge them. We need to put this front and center no matter what branch of medicine we're talking about. And why can't basic scientists do this too? They can care about communities. They can care about children, you know, high school and middle school children learning the basics in science. So this is really, really built into the DNA of this institution.
Okay. And before going to the hospital, they have rotated in community.
Exactly.
And every year they will go back to communities for more sophisticated care.
Yeah.
So there is no what we started to see in a country like Rwanda and elsewhere, where the family believe that the patient is better treated in a hospital when we can treat the patient at home. It's less costly, it's less disturbing, and also it gives you another approach to the community where you live.
Yeah, so in my paper, I emphasize equity through the entire bench to bedside to populate society. In other words, basic research. You have to have the sense of equity, not only in your research, but in your education, in your decision-making, all the way to climate change and its impact on equity. So I think that's, to me, your school's got the really right vision. And that's how we should train all health professions in the future.
And I think the world will go there.
Thank you.
Victor, can you all hear me again now?
Yes.
Yes.
Oh, good. We had a catastrophic IT failure, multimedia room failure.
I thought maybe you were having a little get together at 10 Downing Street.
With the caterpillar cake. The caterpillar cake will be his downfall. We've only got 4 minutes left. I want to just make sure, thank you so much, Victor, that we get Dave Gendell, Chair of the Duke Global Health Institute Board of Advisors, to ask his question. Dave, over to you. You have the final question.
Thank you, Gavin. Good to have you back with us. And thank you also to Agnes and Paul for a terrific discussion. And on behalf of the DGHI Board of Advisors, I wanted to ask, what are the most important lessons learned on global vaccine distribution to make it more equitable for future pandemics?
There are lessons we learned that we are not ready to be able to apply. There are so many people I want to jail for crime against humanity. So I'm going to give the floor to Paul.
Thank you. This is one of my pals from when I was an undergraduate. You know, I don't know which one to elevate. For example, we're not arguing, either of us, that you know, if you have a research powerhouse like the United States, like Duke, NIH, Harvard, you know, it's not that we're trying to move all of this, all the basic science or the development of new tools, you know, to this continent and not have any, you know, optimism about solidarity. I do think that we've learned a number of lessons or relearned a number of lessons. For example, you've heard us talk a lot tonight, Dave, about health systems. I mean, when we were students at Duke, if you said health system, that just meant the Duke University health system, right? But, you know, what is the national safety net system? You know, how do we push forward coherent policies that don't vary county to county, state to state, and that can be improved along the way as we learn new things? But I do think that I'm going to elevate a little bit. I think one of the things we've learned here, that has been learned here on this continent, and again, not by me, but over decades, is, you know, if we don't have here at least some manufacturing capacity, scientific capacity, and of course, care delivery capacity, you know, there's a worry that, you know, we'll be last in line again. I don't know if I should use first person to say we, but I mean on this continent, and I feel like I'm part of it too. And so I think those are when she says there are people she'd like to jail, I don't want to ask too many questions, but I'm not on that list.
I'm sure you do. So one thing I
30 seconds. Sorry to interrupt. We're running very short on time. So 30. You get the final 30 seconds, Agnes.
Yes, I just want to say that what I have learned personally is that when you have a system that are people-centered, you always do the maximum with the little you have. And we don't know what tomorrow is made of, but we need to apply that, how to build a system. And that's what has brought Rwanda here, where we are with the COVID pandemic. We are managing it with little means, but so well, because the people in charge have created a system. So we need to redefine also resiliency.
Thank you so much, Agnes. And Agnes, I need to chat with you because I wrote a piece with Fatima Hassan in South Africa and Cameron Abbasi for the British Medical Journal called Profiteering from Vaccine Inequity. Is it a crime against humanity? So we should chat. So we've run out of time for questions. I'm so sorry. I need to wrap up. And I think actually, Agnes said something earlier, just 3 words, well, 4 if you include and which really, I think, captures today. She said, prove, act, and love. Prove, be science-based. Act, it's about action, not just words. And love, the basis of global health, action and cooperation for sure. Thank you, Agnes and Paul, for your wisdom and your wonderful insights. It was an extraordinary privilege for all of us to hear from you today. I would like to thank the students here at Duke, at UGHE, and at Carrboro High School for their questions. I want to thank DGHI and UGHE jointly for putting this event together. And last, but certainly not least, thanks to all of you who attended today, those in the room I see in Rwanda, those who tuned in through Zoom. Thank you so much And that is a wrap. Good evening, everybody.
Thank you for having us. Bye-bye.